So when you provide one or more clinical findings, it'll propose a set of plausible diagnoses. But the nice thing is it can also explain why a diagnosis is listed. It's not a black box. It can actually tell you here are the reasons why this diagnosis is on the list. It can propose questions to obtain other clinical findings that can discriminate among some of the top diagnoses. It can support the absence of a finding as well as mandatory findings, but it doesn't provide any treatment guidance. This is only an application that helps pin down a diagnosis when you don't know one already. So the knowledge base was actually started in 1984, and believe it or not, it's curated manually. There are some projects we have that are looking at how we can automate this by pulling information off the web and out of textbooks. There are over 2,500 disease profiles and over 5,400 clinical findings that include demographics, history, physical, lab findings. There are about 54 findings per disease profile on average. And there are over 1 million explicit and implicit relationships between findings and diseases. It also supports concepts of disease prevalence and what I call disease urgency, how critical it is if the patient has this diagnosis, you need to know about it in terms of time. And then finally, it also includes what I call clusters of information where certain findings take more prominence if they come together in clusters. So how DXplain works is that the user selects findings from an extensive vocabulary that it has, and then the algorithm uses the curated data to compute the probability of specific diagnoses. The user can then refine the diagnosis list by answering questions or focusing on findings that they have more confidence in. They can negate findings that they're sure that the patient doesn't have. And then finally, the user can explain the presence of a diagnosis by asking the system. So here's a screenshot of one of the interfaces. There are a couple of different DXplain interfaces, but over here you can see there's a finding lookup. The user here has typed in rash. You can see that out of the vocabulary, there are many, many different kinds of rash, so you can characterize the finding very specifically. They've already put in a couple of different findings, extremity edema, cervical lymph node enlargement, generalized rash, conjunctivitis fever. This in an infant male going on for more than 4 weeks. And immediately, as you enter each of these findings, the disease list will immediately show up so that you can take a look and see what you've got. And you can see down here that in the rare, it splits the common diseases versus the rare diseases. And anything with a flag is something that is very urgent. So if you think it might be that, it's something to pay attention to very quickly. You can see that Kawasaki disease is #1 in the rare disease because its score is the highest. And in fact, these are the classic cluster symptoms that one should think about if you have an infant with these symptoms. You must think about Kawasaki because it's a very urgent thing to treat.
What are the small numbers?
So these numbers are actually, so the users normally don't see those numbers. This is like a debug version. So these are actually internal scores used to rank the diseases. Yeah, so like Kawasaki is 51, and the next one is cataracts disease, which is 16. And then if you click on the disease, it can tell you what's going on. It can say the following findings are compatible with disease. The following other findings, if present, would actually support the disease. So these are all other findings that you haven't entered, but if you did enter them, would actually cause the score to rise even further. And here you can see that there's a cluster for Kawasaki, which is that if you have a fever for at least 5 days and you have 4 out of any of these findings, then you really must be thinking about Kawasaki. So it can explain why the system actually came up with that disease. What's the impact of this kind of system? Well, physicians use it oftentimes when they're stumped, when they can't come to a diagnosis. We'll find that they come to the system to help them find a diagnosis. But one of the things we looked at was, could we use a system like this to actually pre-diagnose patients, help medicine residents diagnose patients better. What we did in this study was we showed a rank-ordered list of diagnostic possibilities from DXplain to residents for specific cases that they read. And so what they did is they would look at several de-identified case descriptions of real patients and create their own differential diagnosis. Then they would run this through DXplain, and then they would create a second differential diagnosis, and we compared whether their first one, how was it compared to the second one. In fact, in all 3 cases, the residents improved the differential diagnosis after viewing what DXplain output. So the idea here is that you can use this kind of system to help teach doctors, as well as have them use it on an actual clinical basis. Another study we did was that the question was, can you actually identify findings in a medical record ahead of the doctor making the diagnosis with a system like this, and perhaps alert physicians to misdiagnoses or get them to find a diagnosis sooner than you would have found it normally? And in this study, we took 8 high-risk diseases. You can see them here. These are diseases that if you miss for too long, something bad could happen. And we said, well, let's find what are the high information findings for each disease in D-Explain. So what that means is certain findings that, if you have them, would really make you think of, say, colon cancer or lung cancer. And then we had 2 physicians review records of these high-risk diagnoses from the RPDR, again, that database that we already have. And it turned out that about 25% of those records reviewed contained these high information findings in the notes of the clinicians prior to that diagnosis being established, right? So think of what that means. That means that those findings that, in D-Explain at least, would trigger that diagnosis to be high up on the list were already sitting there in the clinical documentation ahead of when the patient was getting the diagnosis, right? So the notion there is that if you run the system on data ahead, you might be able to alert physicians to diagnoses that are being missed. We used a natural language program to extract about 74% of these high information findings, and it actually caught a bunch of additional findings that were not as prominent, but that people couldn't even locate with manual review. And so the fact that you can find these findings in clinical records suggests that there's going to be a role for decision support systems that will help diagnose ahead of clinicians, right? And that's a really, I think, that'll be a really big step when systems can augment clinical thinking ahead of time. So some of the ongoing D-Explain initiatives we have, we're looking at methods to enhance and automate database curation. So instead of having experts curate this database, we really want to use machine learning, deep learning techniques, look at the data in our RPDR to try to determine, okay, here are the findings for this disease that have helped predict that particular diagnosis, and use that to curate the database automatically. Because if you want to scale this up in a big way, you really can't do it manually. We're looking at using it for consumers directly. And I probably can't say here right now, but a large consumer website will be using D-Explain as its engine behind symptom to diagnosis checking. We want to use it for real-time decision support. So right now, D-Explain is usually used fact, meaning a physician tries to make a diagnosis, can't make it, then comes to D-Explain for some help. What we really want to do is have D-Explain be sitting there in the background, so as the clinician is actually taking the history, D-Explain is already prompting the clinician, oh, you might want to ask this question because if they have this finding, then you really ought to be thinking about this disease. So really create some user interfaces that will help clinicians use this kind of decision support in real time. And then finally, we have some mobile and cloud implementations of D-Explain going on. Okay, so now I'm going to shift over to the care delivery portion and talk about a project called Top Care. And this project, I think, is just so important because even when you have, some really good work like the RPDR, D-Explain, at the end of the day, you really need to take what you've done from a technology perspective and bring it all the way to the point of care and change how the care is delivered if you want to have an impact on cost or outcome. So the use case I'll use for Top Care is that colorectal cancer screening is suboptimal, okay? And we want to optimize outreach to patients. And if you look at this issue, the reason it's suboptimal isn't necessarily because the test is bad, right? So colonoscopies are actually very, very good at capturing colon cancer. But the trouble is people really, really don't like getting colonoscopies, right? So nobody likes the prep, so people want to avoid it as much as possible. So you have to find a way to help people get their colonoscopy. All right, so if you look at Mass General, we could see that the rates in different clinics of colonoscopy screening were low. So here's a range, but up here is 88%, and some of the clinics were here, some of them were trending down. Overall, and this is just real data from 3 different practices, it just wasn't that great. Now, I know that sometimes at Mass General, some of the rates are actually pretty high to start with. So these rates actually are high relative to national levels, but from our perspective, we want to get it up to 100, right? Why can't it be 100? So the intervention was actually using Top Care to identify patients who needed colorectal cancer screening, and what would happen is that the primary care doctor could use Top Care to actually order the colonoscopy. But if they didn't do anything in a couple of months, then a letter would automatically get sent to the patient, or if they were high risk, they would actually get sent over to a navigator, someone who could specially kind of talk to the patient and help them understand why getting a colonoscopy is really critical. So when we looked at using Top Care for this, we really wanted to create rosters for these patients so that you could see which population you're dealing with. So you could see a graph and just click on a population, and then the population was determined through different analytics. So for colon cancer screening, it's pretty straightforward. You haven't had, a colonoscopy or a barium enema in 5 or 10 years, depending on your risk. But for some other diseases like diabetes, you can actually need some fairly sophisticated rules, again, to curate, to locate patients with that disease. But once you've done that, you can create this roster of patients and see, are they at goal? Have they had their study done? When their next visit is, et cetera, et cetera. And then as a physician or as a population case manager, you could take action on them by sending them a letter, referring them to a delegate, and you can see also whether the risk of them not having the study done is low, high, or moderate, right? This is a key thing because you really wanted to focus on those patients for whom the risk was high, that they weren't going to follow up with their colonoscopy. And then here's the days left, because if you eventually, when the clock ticked down, they would get a letter. So they get a customized letter saying, here's what you're due for, please come in, here's why it's important. Now, if in fact the patient was really high risk, then they were sent to a navigator. Oftentimes the reason they were high risk was because they didn't speak English well, right? They spoke a second language, spoke English as a second language, and so we used navigators who spoke these languages to go in and go through these lists and actually contact the patients and talk to them to help them understand how critical getting a colonoscopy was.